I work at the Royal Marsden Hospital and the Royal Brompton Hospitals as a consultant in palliative medicine. And I'm going to take you through a history of the Royal Marsden, very quickly and briefly, about the place of the acute palliative care services within the hospital. And then I started the Marsden 17 years ago. And so then I'm going to take you through the journey of where I believe and the insights that I have around where I believe acute palliative care services should be within acute hospitals. And I'd of course warmly welcome all your feedback because we keep changing. So the Royal Marsden Hospital opened just over 150 years ago. And why did it open? It opened because William Marsden found a woman on the street, and this is the stained glass window in the entrance of the hospital. And you probably can't see it, but on the right-hand side is a very elegantly dressed gentleman and a woman dying in the street. And at the time, 150 years ago, you could only go to hospital if you had a recommendation. So ladies of the night and low socioeconomic status patients did not go to hospital. And the Royal Marsden was set up to be a free hospital to look after exactly these patients. Some things have not changed. From this morning's talk by Jonathan, we still have this inequity. And so if you read the top line of the first document for the hospital, it says, a number of beds are provided for the use of patients who may remain there for life. And let me tell you, that has been the philosophy of the Royal Marsden Hospital. If you were deteriorating, you were always given the opportunity to stay there until you died. And you will see in the last 17 years how that became something that acute hospitals can no longer offer. And I will take you through that journey of how things have changed. So the range of services an acute hospital will provide by these specialist palliative care services are advanced symptom management and or complex psychological issues, advice and support and education of patients and their carers, consultancy and support for the other healthcare professionals, and the liaison of other services outside the hospital. And I think that encompasses all we do. So what I'm going to explain to you is how we do that and how the model has changed over the years. To me, the best services in acute hospitals are those palliative care services that are responsive obviously to the patient, but also to the referrer's needs. Never forget the referrer's needs. And in every change we've tried to make, we've had to address both issues, patients and the referrers. And in order to do this, you need adequate resources, so the ability to prioritize and be flexible, to see patients, do their MDTs, meet relatives, review strategies, have time for education, 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 education. And in order to change culture of patients and referrers, you need to educate. And each specialist palliative care team needs time for audit and research. Audit to review what they're doing, and research to plan the future. This paper was written by Irene, and being in the Cicely Saunders Institute, one could not quote Irene in at least one slide. But it's very interesting that she wrote this paper in 1998, and nothing is different. What is different is how we deliver the same things. Palliative care is to improve patient satisfaction, family satisfaction, reduce family anxiety, provides better pain control, better symptom control, and increases patients' likelihood to be cared for in their place of choice. This patient was a 28-year-old man. I'll call him JJ. He was a patient of mine in 2005. And at the end of my talk, I will tell you how we would treat the same patient. JJ was 28, he presented, and on the day of admission, this was his CAT scan. He had a spindle cell sarcoma with obvious pleural effusions. His abdomen was a huge mass of tumour. He was 𝐃𝐘, very weak, very frail, had been married a month before, and was desperate for treatment. So there was a big tension. Should he treat? Should we not treat? When we drill down into what JJ wanted what his family and his new wife wanted. What did the oncologists want? They wanted to treat him. So their justification to treat him was he was young, he was chemotherapy naive, it may give him time, it may improve his symptoms and his breathlessness. What did we have to gain? We could at least say we'd tried as doctors. We'd assuaged the feelings of impotence of the physician, which is a very real issue with referrers, giving up. The patient has been moved to critical care, so we were giving him the very best. So he was admitted to critical care, so he could have his chemotherapy, and he would have all the complications of his active management dealt with in critical care. What happened? What did we lose? He moved to critical care for so-called active treatment. The move to critical care made his family believe that he would improve. No matter what discussion took place, he was going to improve. Obviously, hospitals don't take patients to critical care unless they're going to improve. So the whole family had mixed messages. The patient stated that when he was in critical care, he was with a critical care nurse 24/7, and he had no private time with his wife. When we moved him, which was 5 days later, and told him there was no further treatment, the patient was relieved, and he said, no one had told me that I was dying, even though I was. And now I know it. And so he had been unable to discuss with his new wife and family what he really wanted. And because of this, the patient told us of his frustrations, that they were speaking different languages. He actually knew he was dying, but they were not on the same sheet. So the outcome was, he died the next day. His sister was called from abroad, she arrived too late. The only wish he had made was to donate his organs, and we couldn't ask his parents because they were, or his wife, they were so shattered. And we felt that when we said that that was what he wanted, they felt because they hadn't had that discussion with him, they couldn't honour that wish, and we respected that. And the referrers were left distressed, and so what did we gain? Not a lot. And the tension between what we need for our patients and what we need for the doctors to realise should be taken out of the equation. And the only way you take that out of the equation is to bring palliative care further back in the patient's journey, so there is faith in the journey with the patient, so that decisions are made holistically, not in a crisis management. And so to that end, we started an education program. We ran an education program through all our doctors in the hospital, saying, could you please, they were all frightened to have these discussions. We said, any more chemotherapy would do you more harm than good. If you knew that was going to come, call one of the palliative care services, we would come down and do the discussion with you. But please don't say, when you're better and your symptoms have improved, we'll reconsider giving you more chemotherapy. So this was a big, big program we had in the hospital. We also educated them about prognosis and treatment, that there was limited evidence. People with advanced disease tend to underestimate the extent of their disease, and they were over-optimistic about their prognosis, and that goes across the board. Then we addressed the referrers' needs, and there was evidence to show that the stress of healthcare professionals involved with seriously ill and dying patients was caused often by dealing with their own emotions, dealing with their own feelings of failure and helplessness and frustration. And it was an interesting paper that came out saying 1/3 of oncologists reported a high level of emotional exhaustion and clinical depression. So there's no point in changing the way you deliver care unless the people who are going to deliver the care have acknowledged these issues. So we thought we'd take the motion out and start asking our acute physicians to do things that became absolutely more pragmatic. And we asked them to look for the first trigger. So we looked at all the triggers that had initiated a referral to palliative care in 2005. And so we spread the word. Okay, if they've got pain and symptoms, doesn't matter where in their journey they are, just call us. Doesn't matter where they are, just call us. Please call us, please call us. And they did. They started to call us. They started to call us earlier on in their journey. The second trigger point, we asked them, please, and in 2005, there was a whale that had come up the Thames, and it was all over the news. Everybody knew that a whale doesn't come up the Thames. Everybody knew the whale was going to die, but don't be ridiculous. There were vets, there were emergency services, there were helicopters, you cannot imagine the futile treatment that was sent in to rescue a dying whale. And we had this poster up all over the hospital saying, when you know the treatments are futile, please call us. So that's your second trigger point. And those two trigger points actually made a very big impact on how we dealt with palliative care. But the problem was, in this second trigger point, the referrers kept saying to us, but what would we offer them instead? And so that was a very big issue. What would we offer them instead? And so we set up a service called Hospital to Home. And so the referrers were happy because we were now offering them something instead. And essentially we copied David Curran's work in Australia, where when there was no further active treatment, a nurse went to the patient and asked the patient, what do you want? Now this was quite novel. What do you want as the patient? We know what we think we should have medically and nursing, but what do you want? And then we put around what they want, medical needs, nursing needs, OT, physio, social, spiritual, psychological, and the whole gamut went round it. And then the nurse took the patient to their home and handed the patient over to the community services. And of course, we've been doing this since 2007, and Jonathan is now supervising the qualitative research of how this has been received. We have quantitative data and some qualitative data. So to look at the outcomes, the face-to-face case conferences, we are discharging a lot more patients, and 83% of the 509 case conferences have achieved their preferred place of death. Now, in other countries, it may not be a quality marker, and indeed, I would argue that preferred place of death is not a quality marker, but it's the only one we have at the moment. We then went on to develop telephone case conferences because some patients didn't want all these people in their home, and so we did telephone case conferences, and thus far we've done 244. I've obviously made an error there of the numbers, the wrong way around, but 84% have achieved their preferred place of death. But the interesting thing that's come out of the views of the oncologists is not dissimilar. The three main themes that are coming out in the qualitative research, which show loss, transition, and establishing new trust, are what bothers the referrers and the patients. And so it's very interesting. Loss means you giving away something. So if you could start to integrate the service at a much earlier stage of the trajectory, you wouldn't be losing anything, you would just be changing the emphasis from one to the other. As you transition, nobody likes change, and if you're cutting off an acute service to go to a community service, it's terrifying for patients. They're frightened, and it's terrifying for the oncologists. So that transition is a very, very difficult thing, and it raises all sorts of issues about the complexities. And establishing new trust. And trust is not established in a single consultation. So it needs to go back in the trajectory. So how are we going to do this? Diane told us this morning that we will never have the resources to give specialist palliative care to all. And that is absolutely the truth. So what are we going to do? So to that end, what she also said is that people need to be looked after by multiple professions, and they all need to share what is going on. But I would go one step further and say at the middle needs to be the patient. And the only way in our highly sophisticated, complex Western needs to share your record is to have it electronic, because otherwise it's simply not possible. And so we set up a service called Coordinate My Care, which essentially is a clinical service underpinned by an electronic solution. And it can be accessed by the acute hospitals, the hospices, the patients in the community, and the out-of-hours emergency services. So what we are now doing is saying, okay, if we have some mechanism, this is now your urgent care service. When you create a record, the system immediately generates an email to the out-of-hours service, GP service, the patient's own GP, 111, which is telephone advice service, and 999, the ambulance service. So everybody knows what care is planned. Going back to JJ, we now will stop having crises. Let's start planning earlier. Let's ask the patients what they want. And when we've looked at the numbers thus far, if you ask the patients what they want, all they want to know is that when they need help, it comes at the right time, at the right place. And actually, it seems, like has been said by the previous speakers, it's less expensive. So to that end, we now have 12,000. These are not Marsden patients, these are patients across London, and we've just started in January in Surrey Downs, which is another area in the UK. So we've got 12,350 patients, and of the deaths, only 19% of the deaths in London have occurred in hospital. They're more in Surrey, but the numbers are very small, and those are only the reported numbers. We're going back to review the data because of the 52 that have died, 29 hadn't actually filled in their data, so the numbers are tiny. So how has this impacted? We're now getting patients out into the community. We need to educate the generalists. So how has this impacted on the acute services? Well, our oncologists, medical and clinical, CNSs, and dare I say even the surgeons, are referring to the generalists very early on. So the acute palliative care service is no longer seeing the end journey of, well, obviously we look after dying patients, but the complexity and what we're seeing is quite different, because the generalist palliative care is being referred straight out into the community where it should be, where patients want to be and where they're good services. And so how has it affected us? Well, if you look at 2005 and then you look at 2013, the Royal Marston Hospital in 2005 we had about 30,000 new referrals. Last year we had about 50,000 new referrals. We are still seeing, we have the same staff, give or take the same number of patients. But what we are seeing is a completely different type of patient. We are seeing a much bigger number, as from 30,000 to 50,000 in 2013. We are supporting a bigger number because the tiny tip of the iceberg where we are supporting patients, the rest is being done by generalists. And I say to you, the only way we're actually going to go into the future is to have an even bigger cohort that are looked after by generalists. And the acute palliative care team should only now be doing specialist palliative care. It is all any country can afford, is to do specialist palliative care. So what is that translated into? For our acute palliative care service, the level of complexity is completely different from when I started. If we go back to JJ now, with the spindle cell sarcoma, when I started at the Marsden, I don't think before 2005 I had ever seen a sarcoma with brain metastases. Now it's gone, because patients are being treated for much longer than they were treated in the past. They have much higher symptom burden, and the complexities of their care are much higher. And that is what specialist palliative care can do. That is what the generalists fear, and that is what our role, in my view, should be. We do less terminal care. Do you know terminal care is less difficult than that sophisticated, high-quality, complicated care. And so, if you looked at our numbers in 2005, 40% of our patients were terminal care, and in 2013, only 22% were terminal care. And that's reflected by our bed status. When I started at the Marsden, we had 23 terminal care beds, and now we have 8. And so the whole shift is to get patients out and for the acute palliative care service to become specialists. And how do those specialists operate? Now we go back in the journey, so if we go back to JJ, we are now called to see patients before they go to critical care. In the complicated patients, we are now called to see patients and make joint discussions with the surgeons whether or not they should operate. So we're right back in the journey, seeing a completely different complexity of patient. So where will we go from here? Well, I told you our triggers were symptoms and our triggers were futile treatment. But we've got to move forward. We've got to move forward. We need to move palliative care way back, and it needs to be a systematic approach. It really shouldn't be you get a symptom, we'll just do. It needs to be an almost screen and treat approach, because then you will catch all the patients that Jonathan and Diane were talking about this morning who we miss out on. It's interesting that just over 4% of patients in this country die in a hospice. 9.5% die in nursing homes. So we should be screening and treating in nursing homes. We should be screening and treating all over, and we need systems that become part of normal process to identify these patients and give equity to everyone. It shouldn't be the hospital reacting with doctors and nurses. It should be screening and treating as and when required on an equitable basis. So what is our next step? Fliss Murta has done an awful lot of work in getting us ready for our next step, which, funding permitting, we will start in the next couple of months. And so what is it going to be? It's going to be a mechanism for cancer patients where we start thinking about dying with dignity at a much earlier stage. At the beginning of life, it takes 9 months for a family to prepare for a baby. We should reflect that at the end of the life. We all need time to prepare for a death. It needs to be a systematic part of a process. So Fliss has evidence-based how we will do the transition to palliative care in an oncology service. And we're going to trial this in lung cancer, pancreatic cancer, and cholangiocarcinomas, mainly because we have a big pancreatic and cholangiocarcinoma practice at the Marsden, and lung practice, and the prognosis is limited. And so every patient that comes to clinic, if there will just be a systematic approach, metastatic cancer, performance status, acute oncology, and you will go down it will be a flow, algorithmic way, so everybody will get the same access to treatment. And if that works, then we will extend it out, and we will hopefully copy this approach in the dementia work we're doing in the nursing homes. Flow diagram, if you've got this, this is what we want to ask you. So my final message is that last 9 months, and I don't say the last day, that last 9 months is very precious time. It comes like the mayfly and it's gone. And you can never relive it. And its impact for families and carers and loved ones goes on for years afterwards. It's so important we get it right. We need to prepare 9 months before, not on the day the patients die. And so I feel that is the way, through the development of services in the acute hospital in which I work, the development of services and the change in the model of services is my insight to how acute hospitals have had to change. And what they've essentially done is taken the control from the doctors and nurses and put it into the hands of the patients, where it should have been all the time. Thank you very much.